All right. So, Dr. Chen, I want to thank you for being here with us today. We know there are extreme demands on your calendar due to the rapid rise of COVID cases and hospitalizations across the state, coupled with a wide-scale preparation for the vaccine rollout in coming months. It is a great honor as the Legislative Committee Chair to present the 2020 State Champion Award to you on behalf of the California Telehealth Policy Coalition and its 100 plus members. We wanted to recognize your outstanding leadership in the advancement of telehealth policy and practice over the years. This has been a challenging year, to say the least, and we applaud the administration's leadership for its rapid response in navigating this unprecedented crisis. We appreciate the administration's prompt action on the relaxation of telehealth policy restrictions and ensuring payment parity across all payers so that all Californians can continue to safely access care. We specifically commend you for spearheading efforts on the development of the consumer webpage and health insurance lookup portal that were stood up in rapid time to help patients navigate their telehealth options and resources. Your telehealth work beyond your role as Deputy Secretary of Policy and Planning is also noteworthy as a champion at increasing provider acceptance of e-consults, spearheading the UCSF ZSFG e-referral program, and producing extensive published research on the program. You have left an indelible mark on the advancement of telehealth policy, and we thank you for your continued support and leadership. So with that, I want to congratulate you on the 2020 State Champion Award. Here is the beautiful award. We will make sure to get this award to you by mail after the meeting. And I will go ahead and turn it over to you, Dr. Chen, to give a few remarks if you're willing.
Thank you so much, Erin. This is a first. I'm trying to figure out how I should receive it and put aside virtually. I just want to say I'm very honored by this and frankly appreciate the opportunity to step back from thinking about COVID all the time to reflecting on more positive things like where we've come with telehealth and all the incredible potential. I just caught the very end of that last panel and just so excited to hear about some of the initiatives that are happening. I'm wondering, I do have some slides that I was hoping to use. Excellent, thank you. Do I ask you to advance them for me? Oh, perfect. Okay, so just, as Erin was saying, my personal, it was an opportunity for me to step back and think a little bit about where we've come. And so I just wanted to share my thoughts with you. As Erin mentioned, I first became involved in telehealth in 2005 when my colleagues and I stood up this program called e-referral at the time, now called e-consult, at San Francisco General Hospital. And it was really in response to the fact that access to specialty care was such a pain point for our patients and providers, 11 months for some routine appointments. And what's noteworthy is at the time, this wasn't even considered telehealth. That term was reserved for synchronous video visits for people in rural settings. And if you were really radical, it was store and forward dermatology. So really, we were doing this work in telehealth, didn't label it as such. What was interesting was that we did take pains to evaluate and disseminate our learnings. And at the time in 2005 to 2009, I'd say, the only other groups that were interested in the United States were other safety net settings. There were definitely other countries with single payer like the UK, Canada, that came to talk with us. But really, it was interesting because it wasn't until there were significant policy shifts there was more widespread adoption of this. And next slide. So there are many different graphs showing adoption of telehealth. This is one that has a slightly more academic slant. It's a PubMed search with the terms telemedicine, telehealth. And so my 5 years between 2005 and 2010 is nothing compared to the long tail of telehealth. The early adopters, actually it was not 1962. After I got a screenshot of this graph, I went back and I looked at it. That first publication in 1962 is not technically telehealth. They used the word mobile in the title, but it was really 1974 when the first PubMed articles appeared, and you can see it was just like 1, 2, 3 articles until about 1995. But it wasn't until 2009, 2010 with high tech and then ACA. So high tech expanding the adoption of EHRs, and ACA with the real emphasis on value-based care and accountable care organizations, that telehealth evaluation really took off. I will just note that, that long period is not incongruous with what AHRQ has found in other settings. The famous finding that it takes about 17 years for something to be proven and until it's widely adopted. So next slide. These are some more traditional depictions of the growth of telehealth. So you see in 2010, after high tech and ACA, hospitals really leveraged their EHRs to provide telehealth. And then on the right, again, traditionally we've thought of telehealth as a way to address geographic barriers for rural settings, but you can see that as we've advanced, the uptake has really been most significant in urban settings, which are the green bars. Of course, this is all pre-COVID. Next slide. And so, as we know, COVID has really turned our world upside down, including our healthcare system. And I'm going to take one pause and a PSA. For those of you who are not following the news, we now have 41 counties in California that are in purple. We have strengthened our mask mandate, which is something we know works, so that essentially anytime you're outside your home, you should be wearing a mask. We do see this surge in cases. The yellow bar represents delay in data. So the curve is higher than the drop off at the end. And we do anticipate that there will be an impact on hospitals. So this is sobering. It is, again, a reminder of why telehealth is important. But I also would ask that you go back to your communities and spread the word that masking, physical distancing, not getting together with people outside your household, particularly as it gets cold and with the holidays as hard as it is, will help flatten this curve. Okay, so back to telehealth. Next slide. So one thing we're really proud of in California is how proactive we've been. So on March 17th, CMS liberalized its restrictions on telehealth for Medicare. The following day, we were the first state to issue a stay-at-home order, and simultaneously, Medi-Cal required all managed care plans to provide telehealth services to their enrollees. Erin did mention we worked with the health plans and CMA to create this website and centralized directory for telehealth for people who are also commercially insured, as well as recognizing that even though we've done a great job in reducing our uninsured, we do still have 7% of Californians who are uninsured. And although many of them do get care in the safety net, we wanted to make sure that everyone had access to care. And so developed a nurse advice line for Medi-Cal fee-for-service and uninsured individuals. So how are we doing? Next slide. I'm sure that many of you have seen this California Healthcare Foundation poll that just came out recently, I think last week. And there's some top line take homes that I think are worth reviewing. The first is, as we know, there has been a real uptick, explosion, adoption of telehealth from 30% pre-COVID, rising more than 160% to 79% of providers saying that they're using telehealth in September. And of note, most people, based on their experience with telehealth, have a positive experience. They have a more positive experience or a more positive impression of telehealth. But what I would note is the blue bar, which is about half of people say it is more positive, but it's not a full thumbs up. And next slide. I think that's driven by the fact that the majority of respondents' assessment is that telehealth is, it's somewhat effective for providing care. And I have to say that based on my own experience seeing patients in my clinic at San Francisco General, I would agree, because while telehealth is unequivocally absolutely better than no care at all, there are still a lot of things that you can't do virtually. And it all depends on the kind of telehealth you're using. And so in my clinic, which is a safety net clinic, it's primarily using telephone rather than video visits. And none of my patients have smart devices that link to EHRs the way the last panel was talking about. So when I want to find out what my patient's blood pressure control is or glycemic control, I have to get them to read their logs to me over the phone, which is sometimes challenging and certainly time consuming. And so next slide. I think this chart on the left shows that many providers are experiencing the same thing, with only some or few of their Medi-Cal and uninsured patients having access to the right technology. And then this graph on the right is the one that I really want to pause on for a second. Because the question was, would you continue to provide telehealth services post-COVID depending on the payment? And 89% of respondents said that if the payments are comparable, they would continue. But only 42% said affirmatively that they would continue if the payments were lower than an in-person visit. 32% said they were unsure. And so I want to flag this last point as something that I think should be really concerning to all of us, because while equal payment for telehealth visits during COVID has been critical for sustaining our healthcare system, and we know that there are potentially significant investments needed in order to provide telehealth in a robust and reliable way, the truth is that the inputs for telehealth are not the same as for an in-person visit. And I think as proponents of telehealth, we have an obligation to have a value orientation and really be evidence-based in our policies. Next slide. So for example, and I suspect many of the panels may have talked about this already, we need to develop guidelines for when a telephone call is sufficient, when a video visit is preferred, when an in-person visit really is indicated. We have to make sure that telehealth doesn't become an add-on. So that is that when we use telehealth, it really is to expand access for individuals or to services that are appropriate and needed and otherwise wouldn't be accessed, or that it's a high quality substitution for an in-person visit. We need to track experience and quality and make sure they're aligned. There was a really interesting article a couple years ago from Cleveland Clinic that showed that patient satisfaction was correlated with receipt of a prescription for antibiotics, which was not necessarily indicated. And then we have to address implementation and workflow challenges. I do want to call out that particularly in the context of COVID and the raging disparities that we're seeing right now, it is imperative that we address the digital divide in terms of both broadband access, universal broadband access, access to things like iPads, and the technology that's needed to really improve care. And what I would say is that we really need to push on to the next level of innovation, because the potential of telehealth done right to improve access, satisfaction, quality, and cost is huge. So I think it lies in how do we leverage telehealth to get the right patient to the right provider? How do we get access to that super subspecialist who knows your rare cancer or disease? How do we really ensure that our most vulnerable have access to smart devices at home that automatically link to EHRs and are then managed by registries and panel managers to improve outcomes on a population health level? And then how do we push things like hospital at home in a way that are really patient-centered, save us, our society and system money, and actually are better because there are fewer hospital-acquired infections and other complications. Next slide. So I would say that we have had incredible progress, and we still have a long way to go in terms of fulfilling the potential of telehealth. All the work that the Policy Coalition is doing is right on the mark. I do think we have our work cut out for us. And I'll just leave you with a quote on the last slide, which is COVID notwithstanding, and I'm sure many of you have heard this before, we always overestimate the change that will occur in the next 2 years and underestimate the change that will occur in the next 10. And I think that's probably as true of telehealth as anything that we see in healthcare. So thank you.
Thank you so much, Dr. Chen. And again, thank you and the administration for your leadership in this space. I think we have a few minutes for questions, and I'm looking down here at our question box to see if we have any. Feel free to submit them. And I guess while we wait for questions, I guess I have a question for you. And that is, how can the coalition and its members be a partner and a resource as the administration is making decisions as it relates to, what temporary flexibilities should be made permanent? So how can we be helpful?
Yeah. I mean, I really think that, not all telehealth is the same. I mean, we've gone, we've thrown the door open because we had to, and it was the right thing to do. I do think that the coalition has an important role to play in figuring out, what is the right level of care for what kinds of conditions. And so that we're, again, making sure that the investments we have in telehealth, including continued payment for all types of telehealth, are done in an appropriate and value-based way. And so I think there's a big role for real-life pilots and data and feeding that back to the administration to show what works and is also fiscally responsible.
Great. Yeah, and there was a question kind of along similar lines: is what research would be helpful, which you had referenced pilots, and so anything to add or expand there in terms of research?
I think a big question in healthcare generally, and particularly for some of the new models of care, is this issue of substitution versus addition. And when it's addition, is it value add? So for example, if you look at some of the research in the retail clinic space, the idea originally was, could we use that as a way to offset more costly care and get better access? But in fact, most of the evidence has showed that people go to the retail clinic and then they go to their regular doctor also. So it seems to be additive utilization without necessarily any improvement in our typical measures of quality of care or outcomes. And I think, again, telehealth is really important. I think it actually has such potential. And I think it's incumbent upon us to really make sure that we do it in a thoughtful and not a nuanced way that actually allows us to prove the value.
Another question here by Joe is, what can nonprofits do to help adoption of telehealth in communities with high racial disparities?
How deep a pocket does a nonprofit have? I was going to say, there's so much to do. I would say on a policy level, one of the biggest things I think is universal broadband. I actually think that making sure that all communities have access to the infrastructure and kind of the foundational pieces is a necessary first step. Necessary but not sufficient. And again, I've always said technology is only as good as the services on either end. And so again, it's great if you have a smart device in your home that links to the EHR, but unless you have someone who's actively working that data and managing that patient population, you have, information, but not data for action and change. So I would say nonprofits, depending on what your focus and scope is, could potentially have a lot of different targets. On the policy side, advocating for equal access, both by government in terms of infrastructure for broadband, but also health plan coverage for devices. I think doing pilots of patients with low literacy, limited English proficiency, low digital literacy, not just plain literacy, is important. I think there's also a healthcare workforce component where many of our workforce, particularly in safety net settings, aren't as savvy with technology either. And so bringing them up to speed, community health workers, navigators who could potentially work with underserved communities and patients would also be value add.
I think we're closing in on our time, but the last question is, so what is the administration's #1 priority as it relates to telehealth in 2021?
I'd have to say that my head is not quite in 2021 right now. I am very squarely right now in 20. But I will say this: that the administration is very focused on thinking through how do we take the spotlight that COVID has shown on kind of the fractures of our healthcare system and the disparities that are evident at baseline and have only been exacerbated by COVID, and figuring out all the levers we have to address those. So I think telehealth has an important role to play in that overarching goal.
Yeah. Racial disparities and health equity. Yes, very important. Well, thank you so much for your time, Dr. Chen. And again, congratulations on the award, and we'll get that to your office. And again, thank you for being here with us today.
Thank you so much.